Today I would be speaking about how to evaluate ABG. ABG per se means ABG per se means arterial blood gas. So the opposite of it is definitely the other sample that we can withdraw from the blood is a VBG, which is a venous blood gas. Uh, what is the difference between VBG and ABG is that uh, all the values almost they correspond between arterial and venous samples except for the levels of oxygen. So if you want to know the oxygen status of the patient, then ABG becomes mandatory. uh, so this is what happens during in the COVID hospitals. The oxygenation part is very important, and hence the arterial blood gas evaluation becomes very important there. How to approach the ABG? Why do we usually get this ABG done is to know the balance between acid and base of the body. What are the different ways in which you can approach the acid and base? So basically acid is the H ions, the bases are usually the negative ions. Overall, the balance between these two is usually depicted by the pH of body. So the most common equation that is used is the Henderson-Hasselbalch equation, in which we try to determine the pH. pH is 6.1. We'll come to know what this 6.1 is, with logarithm base of bicarb with respect to carbon dioxide. If I say which one value is most important to determine the ABG, so would anybody like to chip in? What is the answer? If from the arterial, I would say there is just one value based upon which the whole pH can be determined. So anybody knows the answer to it? There are so many values in the ABG. Which one value the machine will take to determine all the other values? Any response? No. So it is just the value of partial pressure of carbon dioxide. Carbon dioxide, it combines with water to form H2CO3. This H2CO3, it dissociates to form H ions and bicarbonate ions. So ultimately, the bicarbonate ions are also delivered from the values of PCO2. So ABG machine primarily needs just one value, which is the values of PCO2. What is this 0.03 here? CO2 is being carried in two forms. One is the soluble form, one is the undissolved form. So 0.03 is the percentage of carbon dioxide, the dissolved percentage of carbon dioxide with which it is carried from the tissues to the lungs. So this is the significance of 0.03. Bicarbonate ions has already been discussed. Now what is this 6.1? As I have said, PCO2, the CO2 combines with water to form H2CO3, and then this H2CO3, it dissociates to form H ions and bicarbonate ions. So this 6.1 is the dissociation constant of the carbonic acid into H ions and the bicarbonate ions. So one way of determining the balance between acid and base of the body is the pH. Now, supposingly one ABG doesn't show us the pH. Let us just presume. Then based upon which all values can you predict whether the patient is acidotic or not, or alkalemic? The answer to that is standard base excess. I will show you a few samples of ABG. So based upon the values of this base excess is always mentioned on the ABG strip. So the normal values is between +3 to -3. And if the values are greater than +3, then it is usually considered alkalemic. If it is less than -3, then it is acidotic. So this is another way of calculating it. What is the third way based to calculate the pH is standard ion difference, which is similar to buffer base. Standard ion difference is usually, as an anesthesiologist, we usually don't follow it. It is usually followed by the nephrologist, because they say that the body ions, the sodium ions, the chloride, the calcium, magnesium ions, all those ions, they play a significant role to alter the pH of the body. So this SID is usually preferred by the nephrologist to determine the pH or to analyze the patient's status. What we usually most commonly use, the question that will be asked in the exam is regarding the Henderson-Hasselbalch equation. As I've said, pH is nothing but pK1, which is the apparent dissociation constant of carbonic acid that I've already explained. We know the values of bicarbonate. 0.03 was this solubility coefficient of CO2 at 37 degrees centigrade. PCO2, we all know it is partial pressure of carbon dioxide. So this is ultimately to deliver the values of bicarbonate also, there is just one value that you require, that is the value of PCO2. So that is the most important value that needs to be ascertained by the ABG machine. Now, if I ask what is the need of ABG apart from the oxygenation status, so the most important need is it helps in establishing a diagnosis. It will not tell you one particular diagnosis, it will give you a differential diagnosis. The various diagnoses, and then based upon the clinical history, you need to come down to one particular diagnosis. So it will definitely give you a DD. Secondly, it will help you. We very frequently use ABG for guiding our ventilatory parameter managements in terms of CO2 and PO2. pH, why is that important? Because there are several medications which will not act at the extremes of pH. For example, our vasopressor medications, they usually don't act if the pH of the patient is severely acidotic. And the ABG status, it also alters the electrolyte levels. So along with that, the ABG, based upon how have we customized it, it will give you various other values of hemoglobin, electrolytes, lactate ions. All the ABGs, they differently show different kinds of other parameters apart from pH, PCO2 and PO2. That is dependent upon how have we asked the person who is customizing the machine to deliver us. Supposingly, I don't feel that lactate ions are important, so I will ask them to customize my machine which does not show me the lactate ions. Or if I feel that electrolytes or hemoglobin is not important, then I will ask them in that sense. This is very important. What is important? We directly take ABG in our hands and we start to evaluate it, or is it sequential ABG, the trends of ABG which are important? I think most of us know the answer to that. It is always the trends. The first ABG, when we take it in our hand, as soon as the patient comes to us, the first ABG that comes into our hands, it is very important to correlate the values of ABG to the stat lab values, to the laboratory values, so that we know how well is the machine calibrated. Along with that, we know how well the values of ABG correlate with that of the lab values. So always rely upon the trends and not one single value of ABG. Now, while calculating ABG, how do I rely upon that this ABG is right or wrong? Because there are many errors that are associated while taking out the samples, while evaluating the ABG. Those errors have been divided into 4 stages: pre-analytical, analytical, post-analytical, and post-analytical. So pre-analytical means before the machine starts to analyze that ABG, what all errors can happen. So all the errors related to taking out the sample from the patient. That can be, instead of an arterial, you take out a VBG. There can be air bubbles in the syringe, or you have tagged the wrong name of the person, or you kept the ABG with yourself for 1 or 2 hours, and then after that you are sending that ABG, so that time lag, or you are keeping it at less than an adequate temperature or more than an adequate temperature. So all those errors before the sample is put into the machine, all the errors before that, they are known as pre-analytical errors. What are analytical errors is anything that is related to calibration of the machine. If the machine has analyzed that sample wrong, it is known as an analytical errors. After that analysis, before that sample reaches the patient bedside, all the errors related to that phase, after the machine has analyzed, from that point till the point the doctor sees it in the ward, So from analyzer to the bedside, so it can be a delay of sending ABG. Second, it can be an X person's ABG is sent to a Y person's bed. So all those errors, they come in a post-analytical phase. And once a doctor sees that ABG and interprets it wrongly, the doctor interprets the ABG wrongly, that is the post analytical. So evaluation and interpretation of ABG and patient management based on it, if we go wrong on it, it is known as post analytical error. So these are the 4 errors that can go while analyzing the ABG. In pre-analytical, we have discussed it. It can be a non-arterial, air bubble. Supposingly the heparin that we have taken, it is inadequate. It is more, there is incomplete mixing of the anticoagulant. All those things also. A delay in the sample. You have forgotten to flush the syringe properly, and there is excessive amount of heparin. All these faulty way of collection, wrong patient. One important thing is also this inadequate stabilization of a respirator. Supposingly, a patient comes to me without putting that patient on the ventilator, or immediately after putting, or immediately after changing the settings, if I send an ABG, it is going to show me wrong values. Once the patient comes to you, you have put the patient on ventilator or you have stabilized the condition. Only after that, the ABG should be sent. Because even during intubation, supposingly, as soon as we intubate the patient, if we take out one sample and we send it for analysis, it is going to show us high CO2 values because for some 15-30 seconds, the patient is not being ventilated. So it is good for you that you intubate the patient, put the patient on ventilator, and 5 to 10 minutes afterwards, then you send the patient's ABG. So don't be in a hurry to send the ABG samples. A 2 ml syringe, the hub of 2 ml syringe has 0.05 ml of heparin. It can contain that much heparin. And that much heparin is sufficient to anticoagulate 4 ml of 4 ml, 2.2 ml is the capacity of that hub, and that is sufficient for 4 ml. So basically we just need 0.05 ml of heparin. So it is important that when we take in the heparin sample, we should clearly flush it out nicely. This is an example of the same patient. The ABG has been taken out of the same patient. Now what we have done is, you can see the difference in the values. Here the hemoglobin is 4.6, here it is 6.5. Or in the electrolytes, you see the sodium is 98.9, here the values are 137. So I have deliberately added extra heparin in this sample just to show that how can a heparin, excessive amount of heparin or anticoagulant can dilute the sample and can show you wrong values. The CO2 here is 31, here it is 41. So all the values, they seem to be diluted. So you can say that this patient has severe hyponatremia or severe anemia, or you can say that the CO2 seems to be normal, or the patient has, the acidosis is pertaining to metabolic part, but then that is not so. This is the normal ABG of that patient. So this is just to show how excessive amount of diluent can affect the ABG status. Also, temperature, supposingly, and the time delay. Supposingly, we take out the sample and we keep it bedside, and then we don't send it for maybe 15, 20 minutes, 30 minutes, 1 hour. What happens is, there are active cells inside that blood, and those active cells are continuously metabolizing. So they're continuously using oxygen and they are continuously releasing CO2. So there is going to be a change. Once there is increase in the CO2, the pH will change, the PO2 is being consumed, potassium levels increase, PCO2 values will increase. So it is important that you keep the sample only for 5 to 15 minutes till the time it gets into that ABG analyzer. 5 minutes during summers, 15 minutes during winters, because the cell activity is slightly decreased during winters because of the low temperature. So temperature and duration should be monitored. This again is sample of same patient. Now this sample was sent immediately after taking out at 12 o'clock. And this sample was sent after 1 hour, supposedly. So this was also done deliberately. So you can see the change. See, the pH was 7.327 and it shows 7.262 if we send the sample after 1 hour. The PO2 131, it goes down to 115 because the cells are continuously using it. The PCO2 was 42. After 1 hour, it has increased up to 48.4 because the cells are continuously releasing it. So all the values, they are going to get affected if you keep the sample for long with you. So all these things, they come under pre-analytical errors. This is how this ABG slip looks like. So we have discussed what is pH, PCO2. This is partial pressure of oxygen. This is bicarbonate. What is ACT and STD? This is actual and standard. This is standard in which the temperatures and the atmospheric pressure has been managed. This value is to be relied upon when you are actually trying to give bicarbonates to the patient. Actual is what the patient's actual bicarbonate values are, but if you want to supplement bicarbonate to a patient, it has to be based upon the values of standard. Then this is base excess. Base excess, this is B, which is blood, and this is ECF, that is without the cells, the ECF. This is to be relied upon. So this is the importance of B and ECF. This is CtCO2, which is the content of carbon dioxide. It is usually between 20 to 24 millimoles per liter. Then this is oxygen saturation. These are all the electrolytes, the anion gap lactates, and the atmospheric pressure. Now what is important is before you send your sample in the ABG analyzer, there are 2 or 3 things that are mandatory to be written over the ABG slip when you send the sample. One is, what is the FiO2 at which the sample was sent? Because then you need to calculate at what FiO2 this PO2 is being achieved. So always mention the FiO2, whether the patient is on nasal prong or on face mask or on room air or ventilator, you need to mention the FiO2. You need to always mention the ventilatory setting, whether the patient is on room air, oxygen supplementing device, BiPAP or ventilator. That also helps. And also you need to mention the RBS status of the patient. So this was what should always be written on the slip. And these are all the values that we should be aware about what all is written on the ABG. How to read and interpret ABG. Before we jump on to that topic, always remember, don't just take the ABG and start reading it. Always know the clinical history of the patient before you know what you are dealing with. Because the ABG will have several differential diagnoses. And to come down to one particular diagnosis, as I've already said, to come down to one particular diagnosis, you need to know the clinical background. Only then you can correlate the ABG to the patient stages. So now we come on to the steps to evaluate ABG. There are mainly 4 steps to evaluate. First is always to see the pH and determine the pH of the patient. Second is to determine what is causing that alteration of the pH. Is it respiratory or the metabolic part, the bicarbonate part? Third is to determine, once you know that it's a respiratory cause or a metabolic cause, the third step is to determine what kind of respiratory problem, acute problem or chronic problem, or acute on chronic problem, or what kind of metabolic problem. And then the fourth is to know how well the patient is compensating for a deranged pH. So we are going to see all these 4 steps now. We all know the normal pH. The normal pH is between 7.35 and 7.45. Any pH less than 7.35 is acidemia. Like here, the pH is less than 7.35. And anything more than 7.45 is alkalemia. Like here, it is above 7.45. I will keep on showing you the ABG samples with the examples when we are moving on from one slide to another. Now, how do I differentiate whether it is mild, moderate, or severe acidosis? So anything, let us take it, so anything less than 7.35 to 7.3, till 7.3 it is mild acidosis. From 7.3 to 7.2 is moderate. Less than 7.2 is severe acidosis. So always be careful when the pH goes less than 7.2 because that is severe acidosis. Alkalosis, that is tolerated better in patients. Mild is from 7.45 to 7.5. Moderate is still 7.55, and anything above 7.55 is severe alkalosis. Always remember, patients have a tendency, and even we are not bothered significantly when the patient is in an alkalotic state. So this is here, for example, the pH is 7.35. So it is between 7.35 to 7.3. So this is mild acidemia. Now, once we know what the pH of the patient is, we have to know what is the cause of that deranged pH. Is it PCO2 or is it bicarbonate? After pH, the first value that you will look upon is the PCO2. Only after that, we will take care of the bicarbonate. Why PCO2? The reason being, PCO2 is something that we can work upon, the respiratory component. We can alter it. Along with that, respiratory component, it compensates much faster as compared to the metabolic. So the body will respond much faster if in terms of compensation as well as in terms of disease. So after pH, the first thing that we look upon is the PCO2. We know this Henderson-Hasselbalch equation. pH is inversely proportional to PCO2. So if the PCO2 goes up, the pH goes down. If the PCO2 goes down, it is less, the pH goes up. So always remember, if pH and PCO2, they are moving in the opposite direction, the primary cause is respiratory. If the PCO2 goes up and the pH goes down, that means it becomes acidotic. So the primary cause is respiratory if the arrows are in opposite direction. If PCO2 goes down and the pH goes up, then the primary component is respiratory. We will think about metabolic only as a secondary component, not as a primary component. So if they are moving in the opposite direction, the primary cause is respiratory. With this equation, we also know that bicarbonate and pH, they are proportional to each other. So if bicarb goes down, pH goes down. If bicarb goes up, pH goes up. So if these are moving in the same direction, or even if PCO2 and pH, they are also moving in the same direction. If bicarb, PCO2, they move in the same direction with the pH, then the primary cause is metabolic and not respiratory. For respiratory being a cause, PCO2 and pH, they have to move in the opposite direction. Let's take an example. The pH here is 7.505. So anything above 7.5 is moderate. So this is moderate alkalemia, right? Now we need to see whether this is caused by respiratory component or metabolic. So we first take a look at PCO2. If you don't remember the values, then don't be bothered because there are arrows that are written besides these values. So you can rely upon these arrows. So you see the CO2 goes down, the pH goes up. So they are moving in the opposite direction. So here it is a primary respiratory alkalosis because they are moving in the opposite direction. This is a second example where it is mild acidosis. Now let's see, 53 is the PCO2. The normal value is between 35 to 45. So this is again going up. So we again see that PCO2 and pH, they are moving in the opposite direction. So our hunch is that it is a primary respiratory acidosis. Let's see this case. Here it is mild acidosis because the pH is between 7.35 to 7.3. So it is mild acidosis. Let's take a look at PCO2. Now PCO2 is moving also down. So CO2 and pH, they are moving in the same direction. Then we take a look at bicarbonate. Bicarbonate, the normal value is between 22 to 26. Let's take 24 as normal. So here also the bicarbonate is moving, has decreased from less than 24. So pH, PCO2 and bicarbonate all are moving in the same direction. So here obviously the primary cause is not respiratory and it is metabolic. So this is primary mild metabolic acidosis. Now coming on to few examples of respiratory acidosis or alkalosis. So acidosis, respiratory acidosis means when the CO2 is greater than 45. When CO2 is greater than 45, that means the body is not able to remove the CO2. Now, what are the different causes when the body is not able to remove CO2? So for example, when we have giving anesthetic medications, there is respiratory suppression. So the patient is not able to remove CO2. If there is some CNS stroke, or if there is some muscular weakness of the chest, in all those cases, sorry, in all those cases, the CO2 will not be adequately removed. Let's see at few of the examples. When there is respiratory suppression because of anesthetic or any medications, agents, opioids, or stroke, CNS stroke, central respiratory depression, or there is airway obstruction like asthma, when the CO2 cannot be thrown out of the body, there is muscular weakness of the chest when the chest is not able to expand nicely, or if there is any parenchymal disease which is affecting the transfer of the CO2. In all those cases, the CO2 levels will go up and it will lead to respiratory acidosis. On the contrary, what are the causes of respiratory alkalosis? Alkalosis means when the pH has gone above 7.45. That means the CO2 has gone low. They are moving in the opposite. So if CO2 is less than 35, that means we are hyperventilating. In some or the other way, either the tidal volume is more or the rate is more. So now let us see what are the examples when we are actually tachypnic, when we fear, when we are in anxiousness, when there is pain, when the patient is coming and is an inadequate removal, then there is tachypnea. So CNS causes like pain, anxiety, again a cerebral vascular stroke, during fever, when you are doing exercising activities, trauma, when there is hypoxemia, body will try to take an extra amount of oxygen, so there is going to be tachypnea. Physiological conditions like pregnancy, we know that during pregnancy there is hyperventilation or cardiac failure, or when there is splinting of chest as in when there is pain in the chest and the patient doesn't want to take a deep breathing because then that is the breathing is painful. So that is when the splinting of chest occurs. So during all those cases, or pulmonary embolism, or if the patient has metabolic acidosis and the body is trying to compensate by removing the CO2. So all these causes, they lead to respiratory alkalosis. So now we have determined what is the primary cause of a deranged pH, whether it is metabolic or respiratory. Now we have to determine what is the type of respiratory or metabolic disorder. Respiratory mein jaise, is it acute chronic or acute on chronic? Metabolic mein, is it high anion gap or a low anion gap? We'll come on to that. For respiratory acidosis, we always need to determine the changes of H ions is to changes of PCO2 ions. How do you know what is the change of H ions is? There is this particular chart. I have taken this from Harrison, which shows the various values of H ions at various pH. So once you know the values of pH, we know the values of H ions. So supposingly we take normal pH as 7.4 because it is from 7.35 to 7.45. So we take a central value, 7.4. H ions at 7.4 should be 40. So any difference from 40 to the rising trends of H ions or the decreasing trends during alkalosis, we need to see what is the change of H ions as compared to the change of the carbon dioxide in the body. If the change is very minimal, the pH is not getting affected much. The changes actually, the CO2 has gone up significantly, but the H ions, the pH has not changed much. So that means it's a chronic condition. A patient has a long-standing asthma. Obviously, his CO2 is going to be high, but his body has already compensated for it, and so the pH may not be so much deranged. Whereas in acute conditions where there is some sudden insult to the body is not used to it, the pH is going to suddenly change significantly as compared to the PCO2 values. So it's going to acute. And if the ratio is between 0.3 to 0.8, it's going to be acute on chronic. Let's take an example. Here the pH is 7.315. Let us presume it is 7.3 and the PCO2 is 53. So at 7.3, the H ions is 50. At 7.4, the H ions is 40. So the difference is 10. So this difference is 10 of H ions. And the difference of PCO2, the normal value of PCO2 is between 35 to 45. Let us presume a middle value 40. So from 40 to 53, the difference is 13. So we take the difference of H ions is to PCO2, which is 10 upon 13, it is 0.77. And if it is between this, then it is an acute or chronic condition. So this is a patient admitted in the ICU with a history of asthma. So this patient must be a chronic patient of asthma with an acute exacerbation of asthma. So this is how you determine what is the type of respiratory acidosis. One of the last points to determine what is the kind of metabolic acidosis. So metabolic acidosis is of two types, a low anion gap or a high anion gap. Now to understand how do we determine this low anion gap and high anion gap, our body is always in an electroneutral state of situation. It's in homeostasis. All the positive ions of the body, they are usually equivalent to the negative ions, and that is the reason why we are in homeostasis. So all the positive ions like sodium, potassium, calcium, magnesium, in the body, they have to be equivalent to bicarb, chloride, albumin, phosphate, sulfates, etc. Right? What we usually measure is sodium, potassium, bicarb, and chloride. So basically this calcium and magnesium, these become the unmeasured cations. And the albumin, phosphate, sulfate, they become the unmeasured anions. We rearrange this equation. Sodium, potassium minus bicarb and chloride is equal to unmeasured anions and unmeasured cations. This difference of unmeasured anions and cations, either this equation or the values of unmeasured anions and cations, this is what is known as anion gap of the body. So it is basically albumin, phosphate, sulfate minus calcium and magnesium. The normal values of anion gap is 12 to 16. So to calculate the anion gap, what we usually measure is sodium, potassium, bicarb, and chloride. So a difference between these two, it normally comes out to be between 12 to 16. So if this difference is more than 16, we say a high anion gap. It is more than 16 means either sodium, potassium goes up or bicarbonate and chloride ions, they go down. So this is high anion gap. And if we see the pH as abnormal, as being acidotic, but the difference seems to be normal, it is between 12 to 16, then we say it's a normal anion gap. So what are the causes of high anion gap? When you say that the sodium, when do you say either the sodium potassium goes up or the bicarbonate and chloride, overall it comes down. That is a high anion gap. So the anion gap greater than 16 is high anion gap. It can be counted on fingers. There are only 4-5 reasons which leads to a high anion gap metabolic acidosis, which is lactic acidosis, ketoacidosis, renal failure, and poisoning. Why only in these 4 the anion gap is high? See, the anion gap goes high when the bicarbonate or chloride values goes down, right? So the bicarbonate ion goes down, but then there is something else that is replacing the bicarbonate ions to maintain this homeostasis of the body. It can either be a lactate ion, a ketone ion, a uremic ion, a salicylate or an ethylene glycol ion. Anything that replaces this bicarbonate. So while calculating from the ABG, the bicarbonate values, they go down. And because we are not calculating all these ions, so we say that the bicarbonate values and chloride ions, they have gone down, the anion gap has gone up. So it must be, so this becomes your DD. If there is a high anion gap metabolic acidosis, these are the causes that you have to rule out. Now, supposingly this particular equation remains normal and there is deranged pH. That means there is metabolic acidosis, but the sodium, potassium, bicarb and chloride combination, it remains stable. That is a condition of normal anion gap metabolic acidosis. So in those cases, the bicarbonate will go down, but it will be compensated by body retaining the chloride ions. So invariably for a normal ion gap, the bicarbonate is lost from the body. When will the bicarbonate be lost from the body? When there is lower GIT volume loss. In cases of diarrhea, uretrosigmoidostomy, pancreatic drainage, acidosis, when you're giving diuretics to the patient. So there is loss of bicarbonate from the body. And how is it getting replaced? The body will try to conserve the chloride ions. In a normal anion gap metabolic acidosis, you will see the anion gap between 12 to 16. The bicarbonate values goes down, but the body retains chloride ions. And so it becomes a normal anion gap. Whereas in these cases, it is not the chloride which is compensating for bicarbonate. It is these ions which are replacing bicarbonate ions. Also, one of the causes of anion gap, normal anion gap, is a rapid saline infusion. You give saline infusion, the chloride levels goes up. The bicarbonate already definitely has to go down then. And so the equation remains harmonious. Let's take this example. Now, the pH of this patient is 7.336, so it is mild acidosis. The PCO2 is 31.2, it is also going down, and the bicarbonate, as has been cited before also, it is also going down. So pH, PCO2, bicarbonate all moving in the same direction, so it is a primary metabolic acidosis. Now let's take a look at the anion gap of this patient. It is 17.3, because now we know that it is a metabolic acidosis. So now we want to determine whether it is a high anion gap or a low anion gap metabolic acidosis to make out a differential diagnosis. So the anion gap of this patient is greater than 16, it is 17.3. So we know the 4 causes of high anion gap acidosis. So it is renal failure or any poisoning or lactic acidosis or diabetic ketoacidosis. Now this ABG has been, that is when we say that the clinical history of the patient is important. This ABG I have taken out from a patient of renal failure who is on hemodialysis. So basically here the bicarbonate ions, they are not being replaced by chloride ions. They are not being replaced completely by chloride ions, but they are being replaced by uremic ions. So we know that the cause for this metabolic acidosis of this patient is this uremic ions. The last, we have seen types of respiratory acidosis and acidosis. We have seen types of metabolic acidosis. Now the last part is to determine the types of metabolic alkalosis. Alkalosis means the body is trying to save the bicarbonate ions. So all those conditions in which the bicarbonates raise, the pH also raise. The bicarbonates, they are being preserved in the body. That will lead to metabolic alkalosis. So either the H ions are getting lost from the body or the bicarbonates are increasing in the body. So that will happen when there is loss of H ions from the body. So that will usually happen when there is, when supposingly a patient has a nasogastric tube and complete fluid from the stomach is coming out from that nasogastric tube, or a patient is continuously vomiting. So that is when the H ions from the body will be lost and the body will have an excesses of bicarbonate ions. So metabolic alkalosis is of 2 types. One is how to determine, we always measure the urinary chloride levels. If the patient has a nasogastric tube, the H ions will be lost. Vomiting, volume loss, diuretics, in any form, the H ions are lost from the body. The body has excesses of bicarbonate. Now, if the body is losing fluids, what will the body want? It will try to conserve the water. In terms of conserving the water from the kidneys, it will conserve the chloride also. So if the urinary chloride is less, the body is trying to retain as much as chloride possible. If body is trying to do that, that means the volume of the body is less, and that is the reason why we are holding it back through kidneys. So if the urinary chloride levels are less, that means you give fluid to that patient and the patient will be settled. So if the metabolic alkalosis, you see that the urinary chloride levels are less, that means the volume of the body is low. You give volume to the body and the metabolic alkalosis will be settled. On the contrary, if the body is not trying to conserve the chloride ions, that is when it becomes a chloride resistant metabolic alkalosis. There are 2 causes of it. One is hyperaldosteronism and hypokalemia. What do? Usually we don't do anything in these cases, but if it is severe metabolic alkalosis, then there is just one drug that you can give to overcome metabolic alkalosis, which is acetazolamide. We come on to the last and just 2-3 minutes for compensation. How do we calculate the compensation? Our body has a natural homeostasis. So to balance the pH of the body, if PCO2 goes up, the bicarbonate will also go up to maintain the pH. If bicarb goes down, the PCO2 will also go down. So the respiratory and the metabolic component, they always work in coordination with each other. So if CO2 and bicarbonate, both of them are moving in the same direction, you are happy in the ABG that, okay, one system is trying to compensate for the other. For example, here, the pH is 7.336. It is mild acidosis. The PCO2 is low. They are moving in the same direction. So this is metabolic. We know it is metabolic. Now let's see, the bicarbonate is going down and the CO2 is also going down. So the bicarbonate is going down, the CO2 is also going down. So both of these are trying to compensate for each other. So we know that one system is trying to help the other. What is the compensation? If we are in an acidotic state, the CO2 is going up in acute stages by 10, the bicarbonate will move up by 1. In chronic conditions, when the body has got used to that CO2, the bicarbonate will go up by 4. So it is 1, 4 compensation by the metabolic component. On the contrary, if bicarbonate goes, this is during acidosis, respiratory acidosis. During metabolic acidosis, if bicarbonate goes low by 1, the PCO2 will go down by 1.4. So you can cram it up in a way 1, 4, 1.4. It is easy to learn that way. During acidosis, the compensation is 1, 4, 1.4. And during chronic, the compensation is 2, 4, 0.7. If CO2 during alkalosis goes down by 10, the bicarb goes down by 2. In chronic, it goes down by 4. So it is 2, 4. If during alkalosis metabolic, the bicarb goes up by 1, the PCO2 goes up by 0.7. So we know usually metabolic alkalosis is tolerated well. For chloride responsive, you give fluids to the patient. If it is untreatable or resistant, then you may try giving acetazolamide. There are some tricky situations. What if you see that the bicarbonate and PCO2, they are not moving in the same direction? That means they are moving in the opposite direction. It means that both the respiratory and metabolic components are responsible for the disorder. For example, here, it is moderate acidosis. The CO2 is going up. Now to compensate, we may say that this is primary respiratory acidosis. To compensate this, even the bicarbonate should have gone up, but the bicarbonate is going down. So the CO2 and bicarbonate, they are moving in the opposite direction. So both of them are responsible for this deranged pH. Always remember, the compensation is not going to be 100%. It will be less than adequate. But if the compensation goes over and above what you are expecting, then it's a mixed disorder. There is also one more entity which is known as gap-gap ratio. Supposing there are two conditions which are simultaneously lying together, how do I know whether it is a pure metabolic acidosis or a pure sometimes the conditions they sort of overlap each other. For example, a diabetic ketoacidosis will have metabolic acidosis. A diabetic ketoacidosis having diarrhea, that means there is a loss of bicarbonate from lower down track. So, or an HIN loss from HIN loss. So how do you know whether it is a metabolic acidosis or a metabolic alkalosis? For that, we calculate the delta gap ratio or the gap gap ratio, in which we see the difference of the anion gap to the bicarbonate. If it is 1:1, whatever is the difference of bicarbonate is exactly the difference of anion gap. It is purely high anion gap acidosis, metabolic. If the ratio is less than 1, it is a non-anion gap metabolic acidosis. And if the ratio is greater than 2, then it's a combination of metabolic acidosis and alkalosis. I have also given one more example right here. We know that in this example, the PCO2 is going up for acidosis, the bicarbonate is going low down for the acidosis. How do I know what is more important, the PCO2 or the bicarbonate? So you always take out the ratio. For example, there is a pH of 7.25. Bicarbonate has gone down from 24 to 16 and PCO2 from 40 to 60. So the PCO2 has changed by 50%, whereas bicarbonate has changed only by 33%. So we know that this is the primary culprit. This is the secondary culprit, but then more important is the PCO2 component. So these were just few examples. These were my references. Sorry, I've taken it too long. Thank you.